mai, tēnā tātou. Tuatahira māku mihi kia tātou ko tai mai ko hara mai. Tukuna atu nā mihi ki tō tātou atua. Nāna nei ngā mea katoa. Tukuna no nā mihi ki ai me manaaki a tātou tamariki mokopuna rātou katoa I raro I te kapu o pauri rātou huki e māwiwi ana. Koe nā te kaupapa o tātou I tēnei rā, ko te kupu nui ko te manaaki. Tuturu whakamaua ki ati nā. Hui e tae ki.
Kia ora hoa, and kia ora tātou. Tēnei te mihi atu ki a tātou, ko Tairāwhiti Ipurangi ki tēnei hui tuatahi mo te tauhou, ka nui te mihi ki a koutou. And also a warm welcome to any members of the public who are joining us via live stream today. It's a pleasure to have you here with us. Just before we kick off, I'd just like to welcome Fraser back into our midst. So Fraser has rejoined Hauora Tairāwhiti and is in the position of communications manager. So welcome, and it's great to have you with us, Fraser. You come at a time when there is great need, so thank you. We don't have a heavy agenda today, but we do have some guests for our closed session coming in at 10:15. So I'm hoping that we can move reasonably rapidly through the core part of our public agenda. There's nothing unexpected on there, and then head into the other parts of our meeting. So we will kick off. So firstly today we have apologies today from Gavin, Tony, Amy is not with us, and was there anyone else?
No, that's it.
Okay. And then we have the register of interests on page 3. Does anyone have any changes to their disclosures to make? Carl, any conflicts in relation to agenda items today? Carl, okay. Then we'll move to the minutes from our meeting of the 14th of December, which are on page 7 of the board pack. Does anyone have any amendments that they would like to discuss for the minutes? Rob?
Oh, not an amendment. Just a query when we get past.
No,
Kate's Pie. Yeah. So I had a question just on page 8, where it's referred to around the work of the Takatū Hub. My question is, will ethnicity data be collected for those who tested positive, specifically Māori data, and will this be shared with Toitū Tairāwhiti and the providers that are supporting their responses?
I'll pass that question to you, Jim.
So yes, the ethnicity data is collected because it's included when the people test positive. The ethnicity that they have chosen it will be recorded when they test positive. So that is shared with the iwi partners in terms of the contacts that they're then made with those whānau and working with them. So yeah, absolutely.
Thank you.
Any other queries on the minutes? Carl, then we'll note and receive those as an accurate record of our public meeting on the 14th of December. Are there any further matters arising? Okay, then we'll go to the action items, which are at page 12. Jim, is there anything for us to deal with on the action items?
So I think the first one there is a couple of follow-ups from Tairāwhiti Taimemiha, and one of them is the localities conversation that you're going to be having later on today. And the other one was specifically around Iwi Māori Partnership Board, and Nga might give some update on that, but perhaps later on as well. And then the other one is the board meeting dates, which have been corrected.
Very good. Thank you. Any queries on the action items? Then we'll move to the performance dashboard, which is at page 13 of the board pack. And Jim, you can take it that we've all been through this. So just if there's any particular matters you'd like to highlight on the dashboard.
Yeah, the immunisation rates, I think everybody would have spotted those, took a bit of a step backwards again, just really up against it, trying to be able to make sure that we are getting children, babies immunised at this time, and made worse over the coming weeks as well. A lot of effort going in between our outreach immunisation service and Tairāwhiti Health in particular to find families and give them the confidence of being able to vaccinate in their own homes. Yeah, effort to try and make sure that that impact isn't being felt by the whānau in the current situation that we're in.
Does anyone have any queries they'd like to raise on the performance dashboard? Heather.
So for me, and I bleat about this, is the acute readmission rate for the 75 plus is up to 18.7%. Which is a little bit concerning, I thought.
Yeah, I'm thinking that there's something, Ian might want to comment on that, but there's something not quite right with that one, Ian, around the 47.9% year-to-date average. So I think maybe that line just needs a little check up.
I'll have a look at that and correct it if necessary and update you.
Thanks, Ian. Sandra.
Thank you, Madam Chair. Did you want to talk about the COVID environment now, or would you prefer to keep that for later in the meeting? I just have a query about.
Jim's going to give us a bit of an update on COVID in his report.
Sure. Okay. No, happy to leave it until then.
Sorry, Madam Chair, but just to go back to that acute readmission rate, I think there is a discrepancy. The monthly rate is the same as the 3-monthly rate. So I think it's just perhaps inserting of the wrong data, perhaps. Yeah.
Thank you, Hiki. We'll leave that one with Ian, and we can just make sure we get an update on that for next month. Anything further? Okay, thank you for that, Jim, and we will receive the performance dashboard. I'll just move into my report for the last couple of months. So although it's been holiday time, it kind of hasn't been. So with our case that was announced just before Christmas, it did mean that for our teams, particularly our vaccination and testing teams, that they were not able to have what we had hoped would be a Christmas holiday, and they stood back up and worked through, including on Christmas Day. And I do really want to acknowledge those staff, and indeed all of our staff who have provided healthcare over the course of the holidays. Really acknowledge and thank you for your commitment to our communities. And so with Omicron now in the community, it has been a busy summer. Takatū Hub has been very busy providing care and welfare coordination, and with the for our small community, what for us seem like quite large numbers, have been very busy with contact tracing and making sure that everyone who is in the position of having been tested positive for COVID are well cared for, and that care is well coordinated. Now that we're in phase 2, Jim, I thought when you provide us with your report, it'd also be useful, not just for us, but for members of the public, to provide a bit of an overview on the changes in the changes that we expect to see in terms of things like testing and contact tracing, and what care looks like for people under phase 2. There has been quite a lot of regional and national work that's gone on already this year. So I can't recall if I told you at the end of last year, but Nara and I are once again chairing the joint governance group for Te Manuataki, and we'll be doing that through until the end of June. So that group now has strengthened terms of reference, which has largely been driven by expectations from the Minister and the Ministry, and they're really aiming to drive a lot more emphasis on regional work, including more coordinated planning, service provision, and COVID-19 care. So this is all part of the ushering in of the reforms and the greater emphasis on regional coordination that's going to come with the reforms. Te Manawa has met, as has the National Chairs Forum, and in the main, those discussions have centred around, not unexpectedly, the pandemic, the health reforms and regional coordination. And we're also meeting on a fortnightly basis the regional lead chairs. So that includes the chair of chairs and then one of the chairs from each of the 4 regions. So we meet fortnightly to just maintain sort of line of sight across the country in terms of regional coordination. So that's kind of what I've been up to during the course of this year so far. I'm happy to take any questions that anyone's got. Or Nga, if you might want to add anything in terms of our joint governance group role in Te Manawa.
Yeah, only to support your kōrero there. Did you miss out the other part you're chairing, the regional governance group? You've got that on as well, eh? So,
yeah.
So just so people don't think we're shirking, there's a hell of a lot of work going on, Madam Chair, that you're undertaking at the moment. It's just what I wanted to say.
So in terms of the joint regional governance group and Te Manawa, so while they are officially almost separate mechanisms, we have combined them together and said, actually, we don't need 2 different regional governance arrangements across the same region. And so we're running the expectations of the minister and the ministry through our normal Te Manawa governance group. And we particularly wanted to do that because, as you know, the Te Manawa group is probably a bit unique in that our governance arrangement is not just the chairs of DHBs, but also the chairs of our iwi Māori relationship boards, and we wanted to make sure that our iwi Māori partners were privy to all of the work that's going on in Te Manawa and not excluded from the new arrangements that have been driven by the minister. Andy.
Yeah, thanks. You've mentioned just how busy the summer has been, and it's no secret to anyone, but there's been issues around the country about staff burnout, and I just wondered if we've got any sort of ways of addressing that at the moment, because it's a definite reality.
Yeah, Jim, I'll pass that one to you as an operational matter.
Yeah, certainly is an issue because a lot of staff haven't had the opportunity of having a good break for a long period of time. And many staff are working very long hours on a daily basis and also covering into weekends as well because of the pace. And for some really bizarre reason, it seems that we get new cases or particular incidents that occur on the weekend. So that does draw people in. And I know a number of people on this call from a staff point of view are very much involved in that, from the commitment to try and make sure that we're doing the best we possibly can. So it is an absolute issue. You'll see that just even from a financial point of view in terms of the amount of growth in our annual leave liability that we've got, because people are just not able to get the leave that they would want to and should be getting. So yes, what can we do about that? Well, we're trying to get people off on leave. Many people associate leave with traveling somewhere, or particularly for those who've got family overseas, to go overseas, and they can't do that. So that means you have to try and encourage them to take some time now, breaks where they're staying locally. We're also having to redeploy people to try and bolster people up and take people off business as usual. So a number of areas within the organisation, we've already stopped business as usual so that we can actually do that. In our planning and funding team, for instance, are very heavily involved in supporting elsewhere. The other thing that has been happening is that we have been getting support from our other from our iwi providers and from our other community providers to be able to help provide the coverage, and we're expecting that to really step up further with the move to phase 3 soon, and I'll talk a bit more about that shortly, but that will mean that we will be helping to redeploy people out of other activities that they might be doing that are less important in this current phase that we're going into.
There has been some talk of some employment action. Is that on your screen?
You mean industrial action?
Yeah.
The members of the PSA's allied health and technical members are going on strike on the 4th of March and the 18th of March. And we received strike notice about that. That's in relationship to their employment negotiations, which are not progressing to their satisfaction. So they're withdrawing a total withdrawal labour for 24 hours on those 2 separate days. So I could talk about that now, or I could talk about that later when I come to my update.
Yeah, whenever it suits.
Rob, will just answer your question in the chat about Māori vaccination rates. So for Tairāwhiti, first dose Māori rates are 90.3%, second dose is 85.9%, and boosted is 58.2%. So that's as of yesterday. To be honest, the boosters are actually going quite well in terms of national averages. So for nationally, the Māori booster rate is 55.9%, so we're above that. And our population rate for boosted is 65.7%. So we do still have an equity gap between Māori and the whole of the population.
Thank you.
Sorry, and did you have something else with your hand up, or was it that question in the chat? Okay. Nā, I'll pass to you if there's anything further you want to add from Te Waiora o Nukutai Memeha.
Yeah, there is actually. We had a really, really good hui. First of all, and I think Josh Hiwatarangi also had that presentation from Taumatarai. We thought it was a brilliant presentation. We just wanted to congratulate on the joined up approach, particularly from the provider network. We thought it was an excellent forum focusing on the 7 mana principles in terms of addressing the kaupapa. But what was really, we thought was a really good part of the program was the focusing on the whānau wānanga and wahanga process. So group learning, we thought was really good. We also got a paper from Joan Maraki around the workforce development and whānau engagement paper around collaborative systems design. Again, it's around the mental health. So that's one of our focuses for Te Waiora Nukutai Memeha. Again, we thought it was an excellent paper. The strategic relevance being workforce development and measuring success and accountability. So we happily supported all of those 6 recommendations. So we're quite pleased with that meeting. Those are the main points to come out of that, out of our last hui come.
Kia ora hoa. Does anyone have any questions to raise with Nā? No. Okay, then I'll pass straight to you, Jim, for the Chief Executive's report, which is at page 15, I think it is, of the board pack.
Thank you, Kim. Just a few highlights for me out of the month. Financial result was reasonably good, but that was really on the back of a not so good financial result in December. We had a number of large expenses in December, which gave us a fairly hefty deficit in there, including an adjustment that came through from last financial year around our Pharmac costs and rebates, which was a negative $1.2 million that would have gone back into last financial year, but last financial year is closed, so it's turned into this one. So that's impacting on our results year to date that you're seeing there. And also we've still got our COVID expenditure in there as well, and our non-specific accrual. So a number of factors in that driving that overspend of $2.8 million consolidated. year to date. I think, Kath, that we're still projecting to be around about budget at year end, but we will, Frac asked last week to have monthly updates on that, which we will now be providing for the board around how we're going in relationship to that. If you just have a look at the bottom, actually, no, it's later on in the financial report. So, Kath, you might just want to go through some of those items in the financials later in the financial report around the things that are driving that that position that we're in at the moment. So, throughput-wise, it's quite good to see that our acute admissions were down and have been down against the trend in the last couple of months, and we're definitely seeing that flattening off in our acute admissions. If you look on page 17 for internal medicine, or you look on the bottom of page 16, you'll see that it's looking very flat for the last nearly 2 years now, disregarding those troughs that we've had with the COVID outbreak and the lockdown in 2020. The pediatrics is we've seen a bit of a spike up in last winter, but that's dropped away again now, so that's good for our population. And you would have seen that earlier with the ambulatory sensitive hospitalisation rate is very much down. In fact, most of our areas we're getting some good responses, and I really again want to give credit to the team that we've got in our reconfigured emergency department. We've got a majority of emergency medicine specialists in there now, and that's really helping to be able to turn things around for whānau at the door, and also our general team of physicians and surgeons, etc., and their registrars that are helping to be much more definitive and enable people to get care up front when they arrive. Still getting considerably large amounts of ED arrivals. If you look on page 19 at the top there, the total amount of arrivals is still very high and on that very steep curve upward slope on the graph there. But the numbers of people being admitted from the emergency department is showing that when you've got that enhanced capacity to respond within the emergency department, then you're able to provide definitive care for people, which often doesn't require them to be hospitalised. Our key indicators, I'm really pleased that we've still been able to meet our targets around faster cancer treatment. It will become difficult over the next few months as we have got people, as the hospital system starts to clog up and it's more difficult to get people around. So we're having to make sure that we keep the team going to make sure that people get through when they're diagnosed or coming through and needing treatment. Those immunisation rates, again, are a problem, and I've talked about those before in the dashboard. Our planned care production has taken a bit of a backward step in the last couple of months, always does over the Christmas New Year period, with reductions of clinics and operating times over those periods of times. So it's gone backwards a bit. You'll see the numbers of people who are waiting for an FSA has now gone up to, it's gone up to 397 in January, start of February. Somebody's popped that number, it's come down slightly again. So more effort required now to try and get that back. It's going to be difficult in the coming month or two as the Omicron wave comes through, because it is more difficult to get people through in those circumstances. And if we have to coalesce and utilise our staffing in acute areas, then outpatients would be an area where we'll need to redeploy people from. So that will be a problem. And if we start to get higher rates of illness amongst the staff, then that could affect both the consultants doing the work and also the other people doing the doctoring bit and the other support staff, the nurses, etc., around them as well for that as well. So we are trying to get as much done as possible before that happens, and trying to get as many people through. That's both with the FSAs, and then you'll see with the SB5, so that's people who are booked for treatment, that's also escalated up. So we're down to a minimum of 27 back in September last year, and now up to 152 people waiting longer than 4 months for those treatments. ED, as we've pretty much talked about. And then there's a few pieces in there later in the report around some of the reports and things that are happening from a national perspective around a variety of areas. And then I've just got a few points that I particularly wanted to highlight. Clinical leadership. ANIL has been working very hard on medical clinical leadership for identifying the new leadership roles there, been out to for applications around that, and there's going to be interviews this week for a number of roles such as the Deputy CMO, the Director of Quality, and the leader for research, and the heads of department roles. So some good candidates coming through. People put themselves through for that. So I think that it will be reasonably easy to select really good people to work with ANIL and the other clinical leads within the organisation around improving our clinical leadership and our response to things like issues and incidents and complaints. Planned care, I've pretty much talked about. Vaccination. Yeah, Kim's given a bit of an update around vaccination figures. We have got a focus at present around childhood vaccinations because our numbers there need to improve. And I know just from a previous conversation that's been on, Ngāti Hauora are particularly targeting children on the coast to be able to make sure that they are afforded protection in the current environment coming forward. We've still got a variety of places and ways in which people are able to access vaccination. The numbers of people coming through is definitely less in the last few weeks. And that possibly is to a certain extent around the fact that we have reached 90% in an overall population in both first and second doses, and the focus, most of the people coming through now are adults receiving their booster doses. But we are still promoting and getting out there as much as we possibly can to try and get more people through vaccinated, particularly with the value that people who are double dosed and boosted have to avoid the consequences of the virus as it circulates within the community. Swabbing and testing. We have with the numbers of cases, and I'll come on to those shortly, the numbers of cases within the community, the numbers of people coming forward to be swabbed has increased, and we're finding it difficult to have the capacity to do everybody that's wanting to get swabbed on a daily basis. We're getting a lot of people wanting to get swabbed who are asymptomatic, and that is not proving helpful. And it's not helpful for them, it's not helpful for the capacity that we've got for swabbing both locally and nationally. But we are putting on some more swabbing hours to try and get through as many people as we possibly can in a day. So we've got swabbing occurring at Watson Park as the main point for that, but you can also get it through general practices. The Watson Park is also being reconfigured to be the place at which we will be distributing rat testing when we move to phase 3 for the wider general public. We've moved to phase 2 already. But in phase 3, we will utilise rats as the first line of testing for people. So I'll just quickly take you through the process around that. So people will identify that they've got symptoms, and they will then go online and to their my COVID pass, and they will register within there to get rats. And they will then go to an outlet to get those rats, and for us that will be at Watson Park in the city, or be Watson Park or Te Tini o Paro, and they will drive through. They will it'll send them a confirmation that they registered onto their phone. They will show their phone with a QR code, and they'll be given a pack of rats. They, when they're registering, they will put how many other people within the household that also would need testing at that time. And they also will be given enough to be able to do everybody in the household, basically three rats per 3 test kits per person. So they will get that supply, they will take those home, they will follow the clear instructions around how to self-test themselves. Basically, you in your pack, you get swabs, you get a little receptacle to put the swab in, and then a little test plate. And those of you who've done a pregnancy test or seen one done will recognize the little test plate very, very readily. So you just take your swab, you swab both nostrils. You don't have to go up as far as a nasopharyngeal swab. Just up there, get a good coating on your swab. You put it into your little test tube. It's got some buffer in the bottom of that. You swirl it around. Some of them you get to squeeze, depending on it's slightly different on the test techniques. You take that out. You put a little cap on, which has got a little dropper on, then and then you just drop the right prescribed number of drops into the little testing plate. You wait 10 minutes, and then it'll come up with lines on it, much exactly the same as a pregnancy test. And except these lines will say it's positive, negative, or positive, negative, or if there's something wrong, it hasn't produced a valid result. If you get a positive test, you'll go back online and you will enter the fact that you're positive. I think you have to enter a negative as well, but you'll definitely have to enter a positive, and you will then get follow up from that, which will then ask you a few questions around your health status. Will also another follow-up around your welfare status and whether you want to get referred through to MSD for support. If you put the health status questions in there, that will then cause you to get follow-up around your health issues. But also you will put in there, you'll do your own contact tracing. So you will be identifying that, who else is in your household, that they are also going to get rat tested. There's a little bit there around making sure that if you've had people yesterday you had a lot of people over for a meal, you shared a meal together and you all took your masks off and were chatting around the table and getting up close and personal with people not in your bubble, then you'll be asked to contact those people and let them know that you're positive and that they should also check and get rat tested. And then you will manage your own self-isolation. You'll go into self-isolation for 10 days. You'll manage your own self-isolation and you will release yourself after 10 days from self-isolation. If you start to deteriorate, you will get in touch with your general practitioner. If you have more welfare needs, you'll get in touch with MSD. And so that will be the pathway for you. If there'll be, in our community, we know that there will be some people who will not be able to follow that whole pathway because they won't have any device that they'll be able to register on in the first place, or they'll be uncertain about being able to do the test for themselves, or they won't have the supports available to them. So for those people, we are planning that. When you go through so at the drive-through, there will be a lane where if you're just coming there to pick up your rat tests, there'll be that lane. You'll just go through, pick them up, off you go, do your thing. There'll be another lane for those people who just turn up there who haven't registered online yet because they haven't got any way of doing that. They just know that they're not well and they need to get tested, so they'll go there. So they go into that lane. We will assist them to get registered online, and if they want help with the test, we will help them with the test. But once they got online and they're confident, then they can drive off and do their own thing. But if they want to help them, there will be a lane where we can help them do the test. And if it's positive, we can also help them with registering that online as well, and put them in the right direction about where to go to. We also anticipate there may be people coming through the line who are positive and also maybe need a quick health assessment at the time that they test positive as well. So we'll be having registered nurses there to be able to do that. The other thing is that for people at this stage, if you do test positive, then you are supposed to get a PCR test as well. So we'll still have another lane for people that require PCR tests. PCR tests will be particularly relevant for pregnant women, people with morbidities, immunocompromised people, etc. So a confirmatory PCR will also be required. So we'll need to be able to provide the ability for people to be able to do that as well. So that will happen both at Watson Park and at Te Tini o Paro. We are still anticipating getting all of the information around every day around people who are testing positive in Tairāwhiti. So we're hoping to be able to still cross-check that. So while people themselves will self-select about whether they need follow-up or not, we'll also be able to just hopefully, once we get up to around about 100 people a day, it may be difficult, but scanning through just to make sure that we know that those people are in the system, so that when I eventually test positive and go through, scan through, and people say, oh, you know, hopefully he knows what he's doing, you know, he's registered with a general practice, and, you know, should be okay. So no, we don't need to worry about him. But, you know, other people may be identified within practices that haven't identified themselves as needing support, that practices know actually this person definitely, we do want to follow them up, we do want to give them a call, see how they're going, make sure their whatever condition they've got is okay at this time. So we're going to try as best we possibly can to still wrap that support around those people. We're working with MSD still through Takatū to make sure that we are not going to, people are not going to fall through the cracks because they haven't elected to tick the box and go through to MSD, and that they're well supported over this period of time. Of course, doing that in conjunction with iwi as well, who've been at the heart of the work that we've been doing. So I'm going to stop there because that's an awful lot of information, and I can see there's a few people with hands up.
Josh. Thank you, Jim.
Thank you for that, kōrero, Jim. Thank you very much, Madam Chair. I've just got a couple of light questions that are actually interlinked. I wanted to ask you, how likely is it that this process is going to change?
Which process? The
process of testing and rats, like you were talking about how our community, this is the process that our community will go through, engage with MSD, engage with Takatū, rat test, PCR test, etc., etc. Like how likely is that kind of process to change?
How long is it going to take?
Not how long is it going to take. How likely is it to change?
To change.
How likely is it to change? Extremely likely. We don't know. We don't have any actual time frame, but it's moving much closer to in the initial discussions about when things might change nationally to everybody being phase 3 was around 5,000 new cases a day, and I think we're probably, I don't know what the number of cases today is, but you know, we're probably going to be close to 3,000 at least today. And already in Auckland they've started to move over to utilization of rat testing already. So it is, I think we're only sort of a week at most away from changing over to this. And one of the driving factors for that is not so much here, but in Auckland, is around capacity to do enough PCR tests on a daily basis. They're now getting quite significant lags. If in Auckland you could get a PCR test done in the morning and you'd have your result back in the afternoon, now it can take 2 to 3 days before people are getting results back, and that's really not helpful in terms of giving people certainty around whether they've got the virus and then taking action. And so that's another driving factor to move over to utilization of rats. Rats are less sensitive, but much easier, you know, to distribute, and people can do it themselves. So that's we're trading sensitivity for speed and ease.
Okay, kapai, thank you for that, Jim. Have we given consideration to, because I have the utmost confidence that you and our senior staff know exactly the process and exactly how things are supposed to go in regards to where and how our community have to go through these things. You're right, there is Auckland is changing, which is an indicator that we will change. But has there been consideration given to how we can help communicate this thing to our community within the team?
Yeah. So I didn't mention and should have done about how people will access RATs on the coast and out west, but also which is through network of outlets in those places. And iwi have already trained up community champions around RAT testing and trained them about how to RAT test so that they'll be able to support people within their communities about how to do it and the implications of that. So that there's a very strong lead there from iwi around making sure that our rural communities in particular have got that coverage of people in their communities who know what to do, why to do it, and how to do it. And the kits will be available within those communities as well, so that they can get them out to people and do them. Yeah.
Awesome. So in terms of our community managing themselves through this process, we collectively have these champions in our community that can help our whānau navigate themselves through all of these processes. Is that what you're saying there, Jim?
Yes.
Awesome.
And then there is the backup there too of the effort that is going through Takatū, and that's of course a joint venture between ourselves and our partners, particularly iwi, and then MSD is taking a lead around welfare from a financial point of view, because we're going to have a lot of people who are going to be off work for periods of time. And for some organisations, and if you're employed, you've got your sick leave. If you're a Hauora Tairāwhiti employee, then you've got special leave. But others, won't be in that favoured position, so they'll need that support. And that's the way in which the network will go. We know that for the majority of people, because they're double vaxxed and boosted, that the impact of the illness will be not as significant. That's the whole point about being vaccinated, also to reduce the transmission. But it's not, the vaccine doesn't completely do that with Omicron, but it's going to blunt the impact of the virus on the large proportion of the population who are vaccinated. But it doesn't completely remove the risk. So some people will still have serious illness and be hospitalized. And you've got such large numbers of people in the population at any given time who will be ill. So that's the major problem around this phase that we're now in, is actually keeping services going. And we're not just talking about health services. We're talking about aged residential care facilities. We're talking about just getting the rubbish collected, enough people able to get on a truck and go around and collect rubbish on a day. And if you're not doing that, then that you start to wind up with problems. So that's what we're trying to do.
Well, thanks there, Jim, because there's been two big points that I've been hearing from the community. It's just that general confusion around what the process is for them. So it's great to hear that our actual response to that is having these community champions that can help navigate our community through that. And also, the other thing that I wanted to point out too is that I've been seeing from our community as well really positive feedback about Takatū, about how prompt they've been, about the packages that have been going out, and that's been a really good response and a really good coordinated effort for us here regionally. So I just wanted to acknowledge that there too. Thank you very much.
Kia ora. Thank you, Josh. Andy.
Yeah, thanks. It's probably an outdated concern, but are you happy with the local RATs test pack availability?
Yes, we've got something like about 30,000 individual RAT tests available currently at the DHB, and we've got more supplies coming this week, and there is a huge amount of RATs coming into the country this week. I think it might be next week, or certainly by the end of the month. It's like something like 20 million or something like that, and I think we're supposed to have 180 million within the next 2 months. So yeah.
Should cover it.
No worries there.
Thank you.
Rob.
Just a question about, I didn't see it in the report, is the numbers of people that have got one of the two variants. Just if we could be kept abreast of understanding the delay with PCRs. I was just wondering, I understand Delta is, the impacts of Delta is a lot worse. I'm just trying to understand what's our numbers of the two groups.
The capacity in the country to be typing each person's virus is severely strained, and so the only time we're going to get a variant is if it's really, really crucial for the care of an individual. So if you've got somebody with, who's immunocompromised or something like that, then you'll be able to get the variant that they've got typed, so you can see if it's Delta or Omicron. And so we're just not going to see, you're not going to see the variants, but we're reasonably confident that the majority of the people in Tairāwhiti currently are Omicron, the BA2 variant, and that is because most of them are linked back to Sound Splash, I should say, and that was the dominant variant from that event, and that's what's been spreading around the country.
So that's a national level phenomenon, Rob. I was reading something in the last day or so that there's only something like about 1,300 across the country that have been typed this year.
Thank you.
Any other questions at that point? I'll move on then. So isolation and quarantine facilities. Just on lab testing, just to let you know that we do have a local capacity to test now, do PCR testing. We are doing on a daily basis. We are able to test people locally here. So we're using that where we want sort of an intermediate understanding of people who are positive. So we're tending to use that in workforces like our own workforce or aged residential care workforces, those sorts of work.
Can you just clarify that's not that's running the lab results locally?
Yes.
Yeah.
Yeah, sorry. Yeah, lab results locally. Yeah. So we've got 3 levels. We've always had the ability to do what we would call a rapid PCR. So we can, a one-off test that we can do within an hour and get an accurate test to see if the person is positive. We've been utilising that mainly within the hospital for treatment purposes. We've got a very small supply of those and have had to manage those carefully. Now we've got what we call urgent testing, which we can get done on today. So people can get swabbed this morning and we can have a result within roughly 3 hours of that. And then there's the routine, which at present means it goes down to Palmerston North at 5:30, gets processed overnight, and we've got results by around about lunchtime the next day. Sometimes that's longer. Yep, sometimes that's longer. Sometimes swabs don't get put into the system for some reason, and it does take longer. So that has been frustrating. Isolation and quarantine facilities. We've been consistently utilising the flats on site here at the hospital. I think we've only got 1 in use at present. Our 6 vans we've been utilising as well. We've got 2 of those out at present, stationed at people's homes where there's one person that they're wanting to have in the van outside, but still remain close by the rest of the family. So there hasn't been sort of an inordinate utilisation of that. And with the move coming through, it's hard to tell how that will impact the use of that, but we've got more capacity. We've got the Hixbo Motel, which has got 6 units there that we've got leased to us for the next 6 months, and we've also got the units that Tūranga Health have put on Te Kuri Marae. So I think there's about 6 or 8 of those there that are also available, and MB have taken the lead around that now, and they have got a contract with Orbit Travel, and they are able to source options for people as well. So that's reasonably well covered off.
Sorry, Rob, you've got another question?
I just had a question. I think just with the application of an equity lens, are we tracking the access for, definitely I think in relation to the rapid PCRs, are we tracking the equity, the access that Māori are having to those quick rapid PCRs?
Well, not specifically. Those are the ones that get done on the urgent ones on a daily basis, where where people are pretty much around accessing the workforce, or we're wanting to look at spread within aged residential care facilities. So yeah, it's clinically driven around what we want to know the answer to that is. But yeah, I'll talk a little bit later around the outbreak, maybe.
Yeah, I suppose, well, I'm just trying to understand if we are aiming for equity, are we making sure that our practice is aligning with access? Yeah.
Access to more urgent testing, you mean? Yeah. So the access to more urgent testing is, I'd have to say, is related specifically to the need to know from a clinical point of view. We need to know this person's got the virus so that we can be altering their clinical care. We need to know that this person's got the virus because they could be spreading it to vulnerable people in the aged residential care setting, or they're a health worker and they could be spreading it to people. So it's not so much, that's what that more urgent testing is being utilised for. Okay, I've just got a few slides that I just want to show you that might help to illustrate a few points. Okay, can you see those? So this is just the pathway that it's very hard for you to see, but it just gives that pathway that people will be going through for testing and the various points within that. We can share these afterwards. So yeah, just to let you know that there is actually being mapped about how it's going to work for people. This one here is just looking at the cases that we've had in Tairāwhiti since back in 28th of January. So that's the latest outbreak that we have had. And you can see there it's giving you the numbers of cases, females and males, the 7-day averages there, and then the total 7-day average. So you'll see we're getting total 7-day average now of just over 8 cases on average per day overall. So that's not exponential, but a very steep climb in the average number of cases that are coming through on a daily basis. And we could get that done split from an ethnicity basis as well. But if you just look at this one here, and I'll just make that a little bit larger for you. This is the information that's coming out of the Ministry of Health about what it's looking like. And you'll see this is really majority of the cases in this up until sort of early in February will be in Auckland, but you can see what the profile of the outbreak looks like there. And I don't have the exact definition about what the profile of the outbreak looks like here, but it will definitely have a factor, or a similar looking factor to here as well. Some of these ones are looking at the way in which the outbreak is developing in Auckland. And you can see there that it's on that low transmission trajectory, which is more equivalent to what has been happening in South Australia, as opposed to that medium or high transmission trajectories which have occurred in New South Wales, for instance. And so that's encouraging. And if you blow that up a little bit more, you'll see what it's looking like there. I think, Anil, we don't have anything more up to date around this in terms of what that looks like now, given that we're up around about here somewhere. Although actually they're now, I think in Auckland, they're now looking at around about 1,800 cases a day. So they're possibly up in here somewhere now. And if you're looking at it from our own, what it looks like from this for ourselves, here's our modelling with a peak somewhere around about in April, towards the end of April, and here's where we are heading currently. So we're a little bit ahead of the pack in relationship to the number of cases that we're getting here in Tairāwhiti. Any questions about those?
Thank you, Jim.
And then on to the rest of life in Hauora Tairāwhiti. The Mental Health and Addictions Facility, we've got to the point now where we've got an agreed concept for the design of that, and we are having to now get into the actual detailed design phase. That's probably going to take around about not quite 12 months to do that. And that will mean that we'll be going out for tender before the end of the year with a very hopeful anticipation of being able to getting started building sometime about this time next year, and around about a 12-month time to complete. So currently projecting to be completed around about this time in 2024. So that's encouraging, but it is, you know, having to keep things moving to make sure that that keeps on happening. The Child and Youth Hub, we have also got the green light to go ahead and do the actual architectural work for that. So we are setting up to be able to do that. Again, it'll be difficult to keep the progress going on that in the current, when everybody is pretty much got their heads down looking at COVID and dealing with that. Recruitment is a big problem for us, being able to recruit enough staff. We've had a little, I would say that we've had a little bit of success around medical staff of late in a number of areas. I'm particularly pleased that we've got 2 psychiatrists coming on staff. One, I think that starts next month, Anil, and then another one at around about May. So that's been really great to be able to get some people coming back here. I think one of them is here for 12 months, and the other one maybe a longer term appointment. And registrars within that service as well. We're definitely picking up people in the emergency department and in anaesthetics. So that's also good to have that. Still problems around trying to recruit registered nurses. And we know that we share that with AIDS residential care and other places as well. Just not enough registered nurses available in the total population to be able to recruit into that. So that's an ongoing problem. So we're having to look at models of care. And Liz is still online, or she might. No, yes, she is. So I would not go past the issues that we've got about trying to find enough midwives, both for our services within the hospital and LMC midwives in the community as well.
I can update a little bit on the midwives in the community, Jim.
Yeah.
That I've got 2 of my staff that have decided to go out to be an LMC. So that's really good for the community. It means every woman should be able to access an LMC. But for me, it's actually by the end of June, I'm going to be 1/3 of my midwifery workforce down, with no one coming forward. So we're going to be in a bit of a crisis situation here. It's just gradually got worse and worse, and midwives aren't moving from other areas and that at the moment. So I'm trying every which way to try and recruit, but I'm not getting anybody responding at all. Even for the maternity quality safety position and the clinical coach position are vacant, as well as the midwifery workforce to actually care for the women in the unit. So it is getting to the point of I'm really concerned for the future for the unit and providing a safe service. We do have nurses, we have recruited nurses, but at the end of the day, nurses can support us and they're absolutely great to be in the workforce, but they can't do the job of the midwife and delivery suite. It's got to be a midwife.
So that's a very similar picture that's happening around the country, and what Liz has been doing around modifying the way in which we are able to provide care with those limitations on it that Liz has talked about seems to be the only thing that is really able to be being done across the country, is to have more registered nurses, have more healthcare assistants to enable the midwives to practice top of scope and to do the things that only midwives can do, and others can fill in around the edges of that. But it's absolutely not ideal, and that's the situation that we're facing here in Tairāwhiti, and other people are facing around the country as well. Industrial relations, as mentioned before, our allied health and technical staff are going on strike for a 24-hour period. We have been able to negotiate a life-preserving services agreement. Thank you, Carl, for the work that you put in there with your colleagues here and union colleagues to be able to put that in place. So that will give us a degree of assurance around cover over that period of time, but obviously it is concerning when we don't have these key members of staff available over that 24-hour period, particularly in areas where, like acute care areas, where the input of allied health professionals is really significant to safe care for people. But we've got our LPS services around that to try and be able to get through that. We are still in negotiations with our senior medical staff. That's been going for a very long period of time, but have agreed now to go into facilitation with them, so that might lead to an outcome in that. We completed the two pay equity settlements with our allied admin clerical workers and our nurses prior to Christmas. There's a little bit of frustration around that because there's a process that needs to be go through to finalise those before they can be made. The details of those can be made known to the admin clerical workers and the nurses. So we're working as fast as we can to try and get that information out to people so that they're confident around the results of that, and then they'll have to go out to ratification of those deals as well. But you will see in the conversations before around financial that we paid out quite a significant amount of money to nurses before Christmas. That was what could be called a down payment on their pay equity settlement. Vaccine mandate. We have got the mandate was to have been on the 14th of February, got moved back to the 24th of February, midnight on the 24th of February, for our staff to be boosted, and we are down to less than 10 now that still need to get their booster by midnight on Thursday night, so that we're all compliant with the vaccine mandate. Our oxygen and environmental work, I said before, it's unfortunately we haven't been able to complete all of that prior to the current wave of Omicron that's coming around, but we've got our good facilities in place, and some of that work has been completed, such as in the emergency department, creating 2 extra negative pressure rooms there for people to be assessed and managed in the early phases of their hospitalization. And we've got the additional capacity outside in that to be able to stream people there, that are non-COVID people. So reorganizing the way in which the emergency department works to create red and green zones more effectively than what we're able to do in the original outbreak. We have got more work to be done there to create in the resus area cubicles within that, so that they're negative pressure cubicles, so that we can have much more greater capacity there. We have been working upstairs in Ward 5, the medical ward, we've created another 4-bedded room that is negative pressure there, and are converting the end of the ward into effectively a negative pressure unit, and then also have the money now to convert all of the single rooms, side rooms in that ward to be negative pressure as well. It's just a case of having the time, the resources and the time to get into that. And then the intensive care unit, converting half of that into our COVID negative pressure area, splitting off things like the sluice room to make 2 sluices, so that you can close one side to be red and the other side to be green, and also convert all of the cubicles within the intensive care unit to be able to be negative or presumably positive pressure if we need that as well. And Planet Sunshine, the work has started there to convert a large room there into 2 single negative pressure areas within that. So that's progressing well. And maternity, convert one of the delivery areas into a negative pressure delivery area. That's held up a bit by getting some aluminium doors to go onto that, but I haven't had an update about when they're coming, but they're definitely on the way. So that's part of that, just on $5 million that we've got to spend to create that capacity on site within the hospital. Site reconfiguration, $6 million. That's $4 million, $5 million for the oxygen environmental work, and the other $1 million is that we have for the replacement of the steam pipes underneath the building that are at the end of their life, and now that is also going to be joined with the report that we've got on carbon neutral for the hospital or for the DHB, which shows that around about 75% of the carbon that we're emitting is in relationship to our natural gas-fired boiler. So we have got a plan to replace that with smaller electric-powered boilers that will be put at various places around the organisation where the hot water or the steam is required, and that will very significantly reduce our carbon footprint and also link into the money that we've got for the need to replace our steam lines, and we'll also be able to access ECA funding for that work to replace the boiler. And then the other, and we also got $4.5 million. I think before we got $2.5 million or $2 million to buy a new generator, and it wasn't going to be enough because we needed the generator and replace some of the switchboards. We needed $4.5 million. We've got the $4.5 million to do that as well, to be able to replace the generator and the switchboards for the hospital. Resilience and resurgence planning, just that's just around being able to have our planning about what we need to do with coping with up to, I think the modelling shows we may have up to 28 people in hospital at the peak of the outbreak, and how we would accommodate those 28 people and how we would staff that, which will definitely mean that we will need to slow and possibly even stop non-urgent planned care and possibly other parts of the organisation work as well, to be able to have enough staff to be able to provide the care for that many people in the one ward, which will be Ward 5. And also we're mindful that resurgence and resilience planning needs to be not just for the DHB itself, but for the service. We know that at present aged residential care is under a lot of strain with staff members who are ill and people in aged residential care who are currently positive for the virus. So if that escalates, we will need to mobilise other help to be able to go there and keep those facilities running and open and the people cared for, because we can't allow, we need to keep that capacity going forward. ED facility I've talked about, generation uptake, ecological upgrade done. Health reforms update. We've got 2 of our staff members now have been seconded to roles within the interim Māori Health Authority. Nicola Eho has been there since before towards the end of last year, and now Craig Green has been seconded into the role of CFO for the interim Māori Health Authority. Both of those are secondments until the end of the financial 30th of June, while they set up their arrangements. So Kath is here as acting CFO over this next period of time. Thank you very much, Kath, for stepping into that. And George Vlad, who's our logistics manager, is also acting up in his role to cover that area as well, because that's quite a busy area as present, as you would understand, with the need for PPE and rats, etc. in the community. So great time to be stepping up, Kath. There was a little bit of an update that Kim and I got last week at attending the National Chairs and Chief Executives meeting. We can probably follow up with that a little bit later around that. Some good news that we've received some additional funding around boosting our capacity to manage people in intensive care here in Tairāwhiti. This is a sort of a more of a medium-term recognition that this is the pandemic has shown that we don't have enough capacity spread across the country around managing people who need intensive care services, and it coincides with the review that we did of our own intensive care about what it looks like now and where it should be going in the next few years' time. So we've got we're looking to get additional funding for nurses and an intensivist to bolster our service capacity here locally here in Tairāwhiti. So that's good news for the population. And the last thing that I've got on my list, because we just talked about it last month, was around cyber security. And there has been a report that's been done nationally. We did signal that at the last meeting around our own assessment, and it has shown that there's further development required around cybersecurity across the country. We actually don't compare too badly with the national average at present, but there's clearly a need to improve that. The experience of Waikato DHB with their malware incursion last year showed that more can be done to try and prevent that type of event happening in health services, and government's made $77 million available to be able to progressively improve. We've been steadily moving our functions to the cloud, and that's given us a little bit of a boost in terms of our rating around how we compare nationally. So that's good, but a lot more work to be done. Okay, so I think some of those questions in the thing. Yeah, I finished.
They're all answered. Thank you, Jim, and thank you for a very comprehensive briefing. I think that's provided an opportunity for all of us to get back up to speed since the end of last year, and is I guess really obvious to all of us that dealing with COVID there's a lot more to it than just sort of dealing with the infections, but a whole lot of infrastructure work and staffing pressures to deal with, and a myriad of things that circle around that. So thank you very much for your briefing. I'm just going to check across if there are any hands up for any further questions of Jim. Okay, so thank you for that. We will carry on. We'll carry on with our public agenda. I've asked Rachel to push out our visitors for a bit, and we'll complete the public agenda and then have a cuppa. Kapai. Okay, so we will move on now to the financial report, which is at page 28. And Kath, just checking in if there is anything that you would particularly like to highlight over and above what Jim's talked about, and just noting that FRAC has asked for regular reporting on the forecast out to the end of June as we sort of make our run up to when the reforms kick in.
Yep, so within January's result, as Jim's already alluded to, December was not a good month for the finances, but January's bounced back. Within the income figures there, we have a favourable position of 1.5 million. 780,000 of that relates to pay equity, so it offsets the overspends in the nursing income expenditure. There's 223,000 for vaccination activities, and another 580,000 in there relating to other COVID activities. So that's more than offset the expenditure for the month. Over the last few months, the nursing expenditure is offset by pay equity income in its entirety. Outsourced services, as Jim's already mentioned, we've recruited some key positions. I would anticipate that we will see some drop off in the outsourced expenditure for the period. Infrastructure, you probably should be aware that gas prices have more than tripled, so I would anticipate we will continue to see adverse variances against our utilities. The capital charge for the first 6 months of the year has also come in higher than anticipated, so we will see a continuing trend of overspend there. What we also need to bear in mind is that we've moved some of our budget out into these latter months. So I think we still have some leeway of about £1.5 million in our staffing budgets that will hit between periods 2 and 6. Our forecast year end, the latest forecast we sent off to the ministry has us actually within 100,000 of the budget. So depending on what the coming months bring, at this point, we think we'll be coming back in line with budget. But apart from that, I don't have anything specifically. So if anybody's got any specific questions, happy to take them.
Thank you, Kathleen. It's good to hear that we are forecasting towards budget. It's a consistent message from the minister, the maintaining prudent financial management during the during this last basically 4 months of our term. So thank you for that. Josh, just before I go to you, I'll just ask Heather if there's anything that she'd also like to add as Chair of FRAC. No, all good. Okay, thank you, Josh.
Thank you, Madam Chair. Thank you, Catherine. Just a question of clarification. You had said, what was the conditions for us tracking to budget? Sorry.
So within the last couple of months, we've got a new national gas price, and we utilise a lot of gas.
Oh no, sorry. It was you had said if something happens, then we will still be tracking to, or something doesn't happen, we will still be tracking a budget. And I missed that thing that you had said.
Okay. I think Kath said we'll see what happens.
Yes. So barring anything unexpected or unusual, we are forecasting at this point with what we know to budget.
Yeah, which is a reasonable statement. Yeah. Thank you very much, Kath.
That's okay.
Does anyone else have any finance questions? Kath, the two things go together, but I'm really glad that we're having success on medical recruitment, because that is certainly has a big impact on our budget result when we're outsourcing medical personnel. So that's great. Okay, thank you. We will receive the financial report with thanks and note the good news really that it is telling us. We don't have anything from our subcommittees for this part of the agenda. So item 7.1 at page 37 is the 6 monthly report ending 30th of June about complaints to the Health and Disabilities Commission. And I know this has got confidential on it, but it is now published on the HDC website. So Jim, who's going to just give us a brief overview of this report?
Possibly me, although because I'm not sure if others have had the opportunity to go through it, but it's interesting. I think that nationally there was a bit of an uptick in the complaints in that January to June period at the end of last year. So that was, I'm not sure what might have driven that. Maybe that was because they were down earlier in the year, and then people identify the issues and things that they maybe hadn't brought up at the time for that, but certainly come up. And if I remember correctly, our complaints were up a little bit as well. We've got, as you know, a number of complaints with the Health and Disability Commissioner that have quite long standing ones that haven't been that we've provided all the information back to the Commissioner and are waiting for some determinations of those. So we've got a few out there that are needing to be. Our numbers of complaints do jump around half year by half year. I think it is that they do. Yep, half year by half year. So I don't think there's anything in this report that is showing us anything of concern or something things that we don't know of. I'm not sure if the professional leads have got any other comments on it.
Thank you, Jim. I did just also want to note that they're not a measure of poor care, complaints to the HDC. It shows that our systems for improvement are working, and you know, part of it is when you see what the HDC send back to us, and when they're taking no further action on things, then that, you know, that's a fair signal that that there has been a concern, and there's probably been some things identified to address, but not of sufficient concern for the HDC to be wanting to take action. Josh.
Thank you very much, Madam Chair. Thank you for your kōrero there, Jim. I just wanted to ask, it's more about the data that relates to us as Hauora Tairāwhiti, the outcomes of complaints closed, it was page 71, 10.2. They've closed 4, but there's 10 that were notified through. Do we have an ETA on when those, on the process of those other 6?
Not an ETA. It is a long and difficult process particularly for the families and those people making the complaints, because there's just so many steps along the chain that it just takes a very long period of time. And so once the complaint comes in and we are given time to respond back, and sometimes our staff members will be individually having to respond as well. Once you get that back, then the commissioner takes time to consider that. They then get advice. That takes time. Then the advice comes back. It gets considered by us and any of the practitioners. That takes time to do. So it can go for a very long period of time before those.
It can be years, Josh. It can take years to work through the HDC process.
Thank you very much.
Does anyone have any questions or comment on this report? Heather.
Yes, and there's clearly a correlation between responding to complaints properly on time and it being escalated to HDC, and we have been doing some work on responding to complaints better, which is good news. Well, it's starting to slip a wee bit, so yeah.
You make a good point, and I know there was a huge effort, I think led by you and Noel, but across all of our clinical areas that put a huge effort into dealing with things that were already in the system. So ngā mihi kia koutou. Okay, thank you. We will, I think we're just simply receiving the report from the HDC. We have our population projection data at page 72, which seems to be telling us that we're living a bit longer. Jim, were you or Ian going to just provide any comment on the population data?
The only comment, Ian might have a comment if he's still there, but I would just comment that it is good for our population that our population is growing at a faster rate than the national average. If we were still in the days of population-based funding formula, that would be good, but we're not. So it doesn't probably make so much more important, but I'm sure that the team at Health New Zealand will be making sure that that the amount of funding available for Tairāwhiti and the new order of things will adequately compensate those additional people we've got in our population and their health needs.
Very good. Thank you. We don't appear to have any questions on the population data. Jim, I'm presuming this population data has been forwarded to other providers in the community who are also planning?
I'm not sure about that actually, but we could. Yeah, I don't know. Ian might know that, but I don't know. Well, Ariana?
To my knowledge, it hasn't been passed on yet, but it will be passed on.
Great, thank you. And so then we have our corrected board meeting dates at page 76. There's no decision items in this public session. Did anyone have any items of general business? Okay, then we'll bring this public session to a close. So just before we turn the live stream off, I would like to thank any members of the public and media who have joined us today. It's always a pleasure to have you with us and to be able to share the work of Hauora Tairāwhiti. So ngā mihi kia koutou, and I'll now move to close the public session and enter the public excluded session.